Patients often ask me, what degree of disease or reflux disease do I have? Is it mild, is it moderate, severe? And that's a good answer because it really determines how we treat folks. And so the best way of knowing that is undergoing the test that we'll need to evaluate. Usually the best test that we have is an endoscopy where we can actually see the damage that has occurred from the reflux. But that's not the only thing that we use. We also have to evaluate a patient based on their symptoms, because there are some symptoms that are significantly severe symptoms, such as regurgitation of food, coughing at night, hoarseness. These all represent reflux disease that's causing damage to their upper airway, and those would be considered severe disease. More importantly, if we do endoscopies and we find evidence of Barrett's esophagus or precancerous changes in the lower part of the esophagus, that is certainly severe disease. Reflux disease is a spectrum over time, and so it does progress or can progress in severity over time. Oftentimes people start with having occasional heartburn every now and then, especially if they eat certain foods like chocolate or chili or coffee or things like that. That kind of reflux is normal and physiologic and is very mild and doesn't necessarily need any definitive treatment. However, over time, that reflux can get more severe, primarily because reflux isn't so much about having too much acid in your stomach. It's because over time, the normal valve mechanism that keeps stomach contents in your stomach loosens up over time. Hiatal hernias get larger, obesity and weight changes can occur, and so reflux can progress in severity over time and shouldn't be discounted just because you thought it was mild at one time. Oftentimes, reflux can be confused with other disease states. The symptoms of reflux can often look like other things and vice versa. One of the things that we often see are ulcer disease can cause pain in the stomach, similar to reflux disease. Things like gallbladder disease can often be confused with reflux disease, and I'm often in a situation where I have to test folks to determine, is this a gallbladder problem or is this reflux problem? A lot of times folks come to me and not even realize that they're having reflux because they don't necessarily always have heartburn all the time. Reflux is a condition where stomach contents reflux into your throat, and this can cause things that people don't often feel are traditional reflux disease because they're not having heartburn. These are things like hoarseness, chronic cough, breathing problems. When they lay down at night, they actually regurgitate food in the back of their mouth. They often are wondering why their asthma is getting worse. Sometimes we also see problems with teeth decay, and oftentimes dentists send me patients because they're having reflux and acid eroding, or even non-acid reflux eroding the back of their teeth. Typically, once patients have the surgery, they can almost always come off of their medications, and that's one of the important parts of the treatment. Some of these medications can cause long-term side effects. Some of them can be fairly devastating. So doing the surgery, one of my goals and my metrics for success is that reflux symptoms go away, heartburn symptoms go away off of your existing medications. One of the things that often causes reflux is a hiatal hernia. Hiatal hernia, or the hiatus, is just simply a hole that's in your diaphragm that your esophagus goes through. And it's supposed to be just big enough to let your esophagus go through, which is about 2 centimeters or so. Over time, weight, smoking, genetics, that hole can stretch out over time and become quite large. And what happens is that causes part of the stomach to slide up through that hole into the chest cavity where it doesn't really belong, and that disrupts the stomach's ability to hold stomach contents or acid contents in your stomach. And that's why patients will still reflux contents even on medicine that's neutralizing that acid. Sometimes these hiatal hernias can get so large where most of the stomach shoots up into your chest, and sometimes with other organs such as their colon, large intestine, or spleen. and this can cause chronic compression of their lung over time. And I often see folks where I take them, often patients in their 80s, fix that, and they're able to finally breathe and even come off of oxygen again because it's caused that much problem. Surgeons have been doing fundoplications for decades now. There are a number of different types. Some of the two most common types that we see in this country now are a total fundoplication or a partial fundoplication. The total fundoplication is also known as a Nissen fundoplication, and the partial wrap or fundoplication is called a toupee fundoplication. The big difference is that they both work very well to control reflux disease in the 95–96% range. The thing is, over time, we've done a number of studies with the full wrap, and my opinion, based on meta-analysis and different studies, is that the full wrap has a slightly higher risk of problems swallowing than the partial wrap does, or toupee fundoplication. So we typically, here at Pardee, we typically do a partial wrap when we choose that option rather than the full wrap. And that is surgeon preference for sure, but I think it's based on good quality data that is beneficial to the patient long term. So sometimes I do have to redo fundoplications in the past that have been done in the past. And overall, the rates of having to redo your fundoplication surgery or reflux surgery should be around 4% done at a center with experience and skill, a certain skill set in that procedure. So we do have to do that from time to time, and it can be done. Now, it's a much more risky operation to do it the second time due to scarring of other organs, having to take it apart and put it back together again. So the rate typically is 4% after having to do it the first time, and after we do it the second time, recurrence rates can rise up to around 30%, but it can be physically done. It is a little more risky than doing it the first time, however. So it's really important after a patient has their fundoplication that they follow instructions. They swallow very well, they take their time eating. Those kinds of things all improve that recurrence rate.